If you are only on the audio, we will post a link to this on our website. Okay, that being said, we're going to go ahead and get started. I want to thank everyone for joining us today. Today we're going to be talking about how ACOs utilize waivers to improve the population health management. Right now, this is a pressing time to discuss some of these things as we see lots of changes and regulations and changes from CMS this summer in July. So we're going to run through this, spend about 15-20 minutes on the presentation, allowing for time at the end if you want to email me questions for further assistance. Just as a recap, for those of you that are joining us that are not familiar with the Florida organization that we are currently working with all of our members, we are the Florida Association of Accountable Care Organizations. What we do is we help incent providers to work together to, again, increase quality and deliver better patient service and care coordination. We work with the ACOs throughout the state of Florida, along with ACOs nationwide. Our members are really a wonderful group of state affiliate groups that all share the same goals of working on behalf of ACO professionals. Our members and our business partners have both come together to share in this common goal. If you are looking at the screen right now, or if you're looking at it following in the recording, you will see our founding members. These are the members that helped start ACOs. On the bottom, you will see a showcase of some of our highlighted business partners that really are supporting our organization on an ongoing basis. Okay. If you're looking at the screen right now, you should be able to see something about the current landscape with a chart and graph showing different information based on different areas where you see different groups working to improve care coordination and outcomes. One of the things that we have to remember is that population health management is a cornerstone to the success of healthcare reform. Innovative programs are showing up, encouraging initial results, and providing some valuable lessons as we strive to improve our nation's healthcare delivery system. Given the critical role of payers in population health management, we are seeing more opportunities for them to join and explore new partnerships with private and public payers. Organizations of various sizes and structures across the country are working with their physicians and engaging with patients to better coordinate and deliver high-quality care, reducing expenditure growth. Now, rather than focusing on the critically ill patients, providers now have to examine their practice patterns to implement more population health management, delivery, and care coordination. And if you look at the screen, it shows you a number of the groups that are in fact working towards this on an ongoing basis. For those of you that are joining on the phone, they include physician and provider leadership within your organization, public and health departments, private payers, health and wellness groups, external hospitals, health systems, and non-acute providers, public payers, and again, let's not leave out the external hospitals, health systems, and those non-acute providers. For those of you that will be joining us live or on a recording, I think it's important as our organization develops and helps develop the message about what ACOs can provide to provide a brief refresher about what an ACO is. In an ACO, doctors, hospitals, Medicare providers, and patients come together to coordinate healthcare with the idea of improving quality and reducing costs. ACOs now have been around long enough to quantify some of these results and their efforts. Now, mind you, the transition has not been easy. If you've seen one ACO, you've probably just seen one ACO. because there's a number of models out there for people to follow. The number of ACOs reached more than 400 this year in 2014, with some estimates now still placing the number at more than 600. There were a number of new ACOs released earlier this month, and you can check back on our FLACO's website for resources that will show you as additional ACOs are approved. Our membership extends beyond Florida, and we have members now joining from across the country to share best practice strategies with what we're doing here in the state of Florida. About 14% of the U.S. population is now covered by an ACO. And as of January of this past year, more than 50 ACOs had managed to save over $380 million. And out of that number, half of those ACOs had started in 2012, had already managed to lower their costs. So across the board, it's really providing some significant benefits to our space in the healthcare arena. When we look at why ACOs were developed, you'll hear a common buzzword, and if you were to Google the word, you would see triple aim. And really and truly, for those of you that are already working in our space but are looking to work in it in the future, one of the things that you have to understand is that there's three big things that we do when we improve healthcare. We improve that patient care experience. Again, we want patients to be not only happy and qualified and feeling satisfied with the results, but we also want them to actually be better. So we provide improved population health. And we reduce the cost because, again, the system is to always raise the bar, provide new measures so that we can continue to better the health of our population around us. Now, there are two tracks for where you would hear most ACOs are talking about with what kind of agreement they have. Track 1, they share in the savings generated during the agreement. Track 2 is a two-sided risk model and eligible to receive higher shared savings, but again, you have to prepay if there's a loss. So there's more skin in the game, per se, as far as what your responsibilities would be if you're on track 2. When we talk about ACO waivers and the importance for population health management, a lot of times people outside of the industry are hesitant to understand the true meanings because it really breaks down some of those initial barriers or things that may have not worked in a different integrated health model. But for ACOs, the waivers provide flexibility. These waivers include and support the shared saving program and really are there to protect those beneficiaries and those programs and providers and groups from any abuse or fraud. There's 2 waivers proposed in the waiver designs that were existing. Since it started, there have been 3 new waivers added based on the response of the public. And a lot of the things that we will present over the next few slides, you'll learn about quality measures, the 5 waivers that are in place, and the feedback that we are looking for to receive between now and September 2nd to share for future measures and qualifications. So I mentioned there's 5 waivers. The first waiver is the ACO pre-participation waiver. This is for participants, providers, suppliers can fund the ACO development. In our last presentation, we talked about the infrastructure and the resources that had to be built to support an ACO. Well, one of the things that this waiver does, it allows for that process to build the infrastructure to be in place. And it makes it possible to then fund some of those resources, whether it's for IT, for legal, for consulting, for staffing, for any of those things that you would think would be needed to be able to use those funds in the way that would be needed. Again, we want to make sure that the participants and the providers are using it within the means. So there are rules around how you can use this. And the governing body must approve reasonably related to what the CMS program purposes are. And again, that's going back to our triple aim. But we want to make sure that you're likely to participate when the application date is open. So this is This is the preparation stage. And this is one of the things that they really did to really kind of safeguard and make it possible for different groups to participate. The second waiver we're going to talk about is ACO participation. This starts when the CMS agreement begins, and it protects all parties to the arrangement. Again, there is a governing body of approval, so there is that checks and balance in place, and we want to make sure that everyone is able to participate and follow within the guidelines. So when we think about this, we know that there's a lot of documentation that has to be done in that first waiver. Generally, this ends when the program participation ends. So this waiver is only in place for as long as it's actually in place contractually. The ACO participation waiver of the physician self-referral law, which, for those of you that aren't aware, is the federal anti-kickback statute and the gain-sharing CMP that applies broadly to ACO-related arrangements during the terms of ACO's participation agreement under the shared savings. Well, that sounds like a lot of information, but to really get down to it, it's, again, the checks and balance system of making sure that for certain all ACO-related arrangements, which would otherwise have been prohibited during the terms of ACO participation, are now allowed. And again, there's strict guidelines for this. And we're going to go a little further into it as we go into the next waiver. Our next waiver, which is the third waiver, really touches on probably one of the biggest issues that I personally get emails about or questions about as different groups are looking to join into the ACO arena. And that's we're looking at the shared savings distribution and their Stark Law, anti-kickback, and gain sharing. And again, these are three issues that in other healthcare models may not be approved, even though they may be integrating care coordination and clinical processes. But for ACOs, these are waived for financial relationships among those ACO participants, providers, and suppliers that would normally implicate a Stark Law. Eligible for all those ACOs that are in good standing. And again, those are things from a reporting measures as we talked about in our last presentation and the integration of data to make sure that the data is up to date. Also, when we look at financial relationship related to the ACO, we look at, again, this one generally ends when the program participation ends. But we want to make sure that the financial relationship is reasonable related to the ACO program, and that the financial relationship complies with those laws. So again, in other situations, you may not be able to share incentives. In an ACO environment, we had to make sure that this is something that we could make possible for all participants. And what we're seeing now is that the extensions of incentives are being extended beyond the primary care and providers and the ACOs as we venture into a new arena of having more provider participation and venturing in more with specialists. So we will see more information, and there's been a lot of changes regarding this recently, to make sure that all participants are involved and that everyone knows regulatory what they're supposed to be doing. Our fourth waiver is a shared savings distribution waiver. For those of you that are only participating on the audio portion, I'm going to provide a little information about what's on the screen and then some other information. I don't want you to miss out on this. But this protects shared savings distribution methods, necessary service items that protect incentives for all evidence-based care that is medically necessary. Okay, the duration is not defined like in the past waivers. The particular requirements don't always have to be met. And there are a lot of details where we can go back and forth on specific information. But for you to understand how this really works, the waiver allows ACOs to distribute the use of those shared savings earned by the ACO. This is a waiver of the physician self-referral law, federal anti-kickback, and again, the gain-sharing CMP. In order for this to work, the ACO must have a participation agreement with CMS. First and foremost, they have to be a CMS ACO. They have to have earned and had shared savings during the ACO's participation agreement. So during the period when there was data and when the participants were participating at that time, we need to make sure that they were part of that process. They need to be able to distribute the shared savings to those ACO participants, providers, suppliers, or individuals or entities that were part of the ACO during the year in which the shared savings were earned. When we look at this is one of those areas where we see the distribution model changing because of the quality measures changing. So how the funds are shared and what they're reimbursed for or incentives are being given out for is dynamic and will be changing constantly. And that's something that you can read about on our website under our industry news, because we have a number of resources there that can show you about the quality measures and the goal of really raising the standards continually, approximately every 2 years. The fifth waiver that we're going to touch base on is the patient incentive waiver. This is the one that really allows an ACO to offer certain medically related incentives under that shared savings program to beneficiaries to encourage them to be more preventative with their care and compliance and treatment regimens. So this is how we're getting all the way down to the participant, the beneficiaries, and getting all the groups involved to really make sure that we can be more proactive with our care coordination. In order for this waiver to apply to free or below fair market value inducements to beneficiaries, the ACOs must have a participation agreement with CMS and be in good standing. Establish a reasonable connection between the items or services and the medical care or beneficiary. And ensure the items and services in kind are either preventative in nature or advance a clinical care goal having to do with adherence to a treatment or drug regimen, follow-up care, or management of a chronic disease. And one of the things that we want to make sure is if a person is receiving these benefits while they are being treated within the participant plan, and if the plan changes later on, we don't want beneficiaries to be punished or penalized for the services they received while the plan was in place. And that's something we're going to talk about in future webinars. Now, as of July 3rd of this month, there were new ACO quality measures released. That being said, I think it's important for us to include this on this webinar as we talk about population health management. Because while we look at waivers to put in place, a lot of the new changes and quality measures that they will need to be accountable really do depend heavily on these changes. So, effective for the 2015 reporting period, there are a significant group of changes, okay? There are a total of 37 ACO quality measures that were released. Some of these are new, some of these are revised, and some are in fact being retired. So the goal is as we cross over and make milestones in care coordination, that we continue to raise the bar and the quality benchmarks to continue to improve that health and population health management group for the overall communities that we serve. Right now, if you have questions about these, again, there are resources on our website. CMS is accepting comments by September 2nd. And as we've noticed in the past, and some of the resources available, they do take these comments into strong consideration. And like we talked about the waivers, 3 of those were added based on public feedback. So we ask you to take this information back, go to our website, find these resources, and do what you can to provide value information back to CMS about how this impacts your ACO and physician services that you provide. When we look at the new quality measures, because I split this up based on new, what's been retired, and which ones have been revised, there's a number of them that have been new, that are new. They are listed on the screen. If you are joining us via audio only, we'll make sure that this is available for you after the fact. But again, a lot of them include depression readmission after 12 months, coronary artery disease, and that's against care management preventative services. And again, we want to make sure that the 30-day all-cause readmission measure is really in place. So when we look at these things, and we can provide additional notes on each of these, we want to make sure that we're looking at this and we're understanding that we want to improve the patient experience. When we looked at the proposed measures to retire, some of the ones that we really want to look at are all related to diabetes. Not all of them, but a good portion of them are specifically related to diabetes and vascular disease and coronary artery disease. So these are some big things that you'll be able to find on our website as far as resources linked to those ACOs that are being retired. It doesn't mean that these aren't important anymore. It just means that there is a handle on it based on the ACOs participating that we are now going to raise the bar of what we expect. Another thing is medication reconciliation after discharge. Again, this is about being more proactive with our care coordination to improve that population health and of those of all the beneficiaries. Next, we're going to look at measures that need to be revised. When we look at this, again, we talked last about diabetes, and some 5 component diabetes measures would drop to 4, and 2 of those artery disease. So we were just talking about that. But we want to also grow from 2 to 4 when we look at artery disease and some of the things that we can do. Again, we're not going to spend a lot of time on this today because this is going to be a topic for a future discussion. And we're going to bring in some of our partners and ACOs to be specialists on how this will impact them. And we can show white case and actual studies. But I want to make sure that you understand this information is available. And please go to our website if you have questions. We are wrapping up on time. I'm determined to keep this under 30 minutes because I know everyone is very busy. If you have questions after today's webinar, please send them to my attention. On the right side of your screen, you will find my email. My name is Marcy Rudowitz. My email is mrudowitz@flacos.com. Yes, there's an S at the end of Flacos. Also, you'll be able to find my contact information on the website. Some information to keep you up to date with. We have our agenda going live for the conference tomorrow. Please check back to see all the session options available. We look forward to your participation and to announcing our group of speakers. We also have room for additional sponsors for specific venues and events. So please, if you are interested in gaining exposure for your ACO or organization, please contact me at your earliest convenience because space is limited and we are filling up. Also, if you have not made your plans to attend our fall conference, please click on the link on our website on this conference. I'll leave it open for a few minutes after on the Flacos resources on the side. Or call me so that we can get you registered. We have a great venue at the One Ocean Resort and Spa in Atlantic Beach, Florida. This is a beautiful award-winning facility, and our lineup of speakers are coming all over the nation, as well as throughout Florida. So we want to make sure that you, as well as members of your medical community, are available to come and participate in this wonderful event. That being said, it's now been 30 minutes, and I'm determined to end on time for you. If you have questions,